want to thank you, the organization of this meeting, to give me the chance to have this little speech about how managing frailty in people living with dementia and their informal caregiver. In a world that aging rapidly, it is essential that healthcare systems are realigned to meet the growing needs of older population. The health of older people should not be just a matter of care, but a commitment to maintaining their capacity over the years. And the aging so means, in fact, that preserving those functional abilities that allow people to live independently and with a good life, even in the later years of his life. So, in this context, healthcare system must evolve not only to cure, but to promote the well-being of the older people. Aging itself, it's associated with a progressive homeostatic dysregulation of this complex system. So this vicious cycle of energy dysregulation is defined as frailty. Frailty is a clinical recognizable state in older people who have increased vulnerability, such the ability to cope with everyday or acute stressor is compromised. When a physical frailty is associated with simultaneous presence of cognitive impairment or subjective memory complaint, we can talk about cognitive frailty. So cognitive frailty is the major controversial point regarding the cognitive frailty is reversible cognitive impairment. Some MCI patients, as you can see in the left of the slide, show some symptoms that can be reverted in normal cognition. But however, many MCI patients show an irreversible progressive reduction in cognition. So it's therefore plausible to think that are some modifiable factors that are not related to neurodegenerative disease that has to be taken into account in order to act and to prevent the progression of reversible cognitive impairment. So this slide, as Luke showed you before, Lancet Commission in 2024 dedicated significant portion of its report on dementia management on this multidimensional factor that can be modified in order to prevent the progression of this cognitive decline in a very important percentage of cases. Addressing frailty as a tool to reduce the impact of dementia on patients' lives is a topic widely discussed in the literature. In fact, recent studies show how several trials have shown how multi-intervention domains like physical exercise or better strategy or in nutrition can mitigate the impact on frailty even after 6 months, like the graph shows on your left, the blue one. And this prevention, exactly this action can work as a primary prevention in frailty onset. And furthermore, beyond the risk of onset of frailty is also has an influence on clinical expression of cognitive decline, as shown in the right part of the slide. In fact, a new study published in 2020 on neurology showed, this is a neuropathological study, show how frailty modified the relationship between the neuropathic pathological burden and its clinical expression. What this means? This means that for the same level of neuropathological burden, the presence of higher frailty is related to a higher likelihood to have dementia during life and a less reduced likelihood to reach death in normal cognition. The current medical practice to assess, treat, and monitor frailty is performed basically through clinical setting. So the patient has to go to the clinical setting to make a follow-up. But between the visit, there is no information about the changing status of the patient, the adherence to treatment, the response to the treatment. So in the recent years, there has been a digital transformation in healthcare models, and this new technology could provide aids to measure, monitor, and treat frailty in the older population in community dwelling. And this is a recommendation also from WHO from 2017, which changed the vision from frailty to resilience, stated with the new 13 recommended base intervention in a high COP guidelines that is based on community dwelling. So a technological ecosystem refers to a complex network of integrated technologies, services, and stakeholders that can interact and depend from each other, and that has to involve not only the patient but even their informal caregivers to create a unified and functional environment. I will be very quick on this slide just to know which are the characteristics already recognized in scientific community that a technology should have. And also I just show you very quickly some trials that are already ongoing on Europe, and these trials are not only based on the application of technology in a clinical field or clinical practice, but also are some trials that involve the informal caregiver and population to design better technologies that can fit and can provide tailored strategies to manage older population. But even if there are many studies that are already starting analyzing technologies in healthcare setting, a very new meta-analysis that I cannot show you because it's in submission, but I have the chance to see the result in frailty conference in Toulouse a few days ago, show how the papers that are related and focused on digital technologies and its implication on prevention of frailty are very few. We talk about like 10 or 15 papers analyzing the technologies in managing and preventing frailty. So right now there are no strong recommendation from scientific community to the use of technologies in the prevention, in the primary prevention care. So there is an urgent need to enlarge this research in order to better implement the technologies in healthcare setting. Informal caregivers have also an important role in bridging the gap between healthcare system and so the service that healthcare system can provide and the type of assistance and the service that the patient actually needs. So the burden of caregiving role include a vast of majorities of difficulties that can that have to managing the informal caregivers, such as physical, psychological, and also financial issues. So the primary sources of caregiver burden include the lack of support network, not uses formal or informal device, the problem related to the behavior of the patient, the overwhelming coping skill. So all this problem leads to stress, to depression, to an increased burden overall of the informal caregiver, and so the reducing of it is quality of life and maybe also an early institutionalization of the patient. So even though numerous digital mental health support are already available in the market, only a small proportion address to the adverse mental health present in the informal caregiver. So the results from literature show how the caregivers actually benefit and improve their well-being. They lower their level of stress and increase their emotional regulation after they were trained and educated to the use of the technologies or other kind of skills that can the healthcare profession can provide to them. So teaching caregiver to how to coping skills and how to regulate their self-emotion is important to try to preserve the mental health of the caregiver, and also is an important aspect of the digital medical tools that they can provide space for the caregiver to train and to exercise their skills when they acquire them, and therefore obtaining a good knowledge of the skills. And this can surely provide the caregiver a better resilience and also other tools to manage the stress and the behavior of the patient which they live with. So right now, I'm going to talk a little bit about our clinical practice, but our clinical practice actually is not based on the prevention field, since I work in a neurorehabilitation clinic, but it's more focused on exactly the rehabilitation of the patient that present cognitive decline in different kind of diseases. So not only related to neurodegenerative processes, but also after, for example, strokes or related to Parkinson's disease. So in our clinic, we have two fields of use of the technology. The first of all is in the clinic exactly. So we already start to use the protocol being validated by the literature to treat at home and rehabilitate at home person with cognitive decline, but also we try to design new protocols. So we have some experimental rehabilitation treatment that we are able to provide to our patient when are dismissed. So I present two different cases of use of technology in our clinic and their caregiver perspective. The first one is an 82 years old man that lives at home, and he has a very poor prior digital school. So every time we start the treatment with this patient, we need to explain to him to turn the device, adjust the volume, how he has to interact with the screen. And so the patient use these difficulties to mistrust the digital tools and to mistrust the potential of rehabilitation. So every time he tried to justify their mistakes, blaming the technologies, saying that the exercises are too fast or the exercises are too slow or they cannot interact correctly to the screen because the screen is broke. So in this situation, we actually need the presence of the caregiver close to the patient when the patient perform the rehabilitation. So the caregiver in this case collaborate to the good performance of the session of the rehabilitation training. He has to stay close to the patient and help him interact with the technology. But even if need to stay there, it's every way a good the therapist can give him good advice to manage the behavior of the patient at home, and also he can listen and cope the therapist during the communication, try to understand the strengths of the instruction that the therapist give to the patient, and so he can positively assess the possibility of following a consistent rehabilitation without go to the clinic every day with the patient. But a very different case is the second one.
Ilaria, I'm really sorry. I'm just going to jump in quickly. We're already run out of the time, so if you can present it in like 1 minute.
I'm very 2 minutes. This patient has a very good digital strategies. He has already a computer, he has already a tablet, so he was very motivated do rehabilitation. He was very optimistic. He tried also to ask the therapist to do the rehabilitation all alone without the synchronous activity with the therapist. And of course, the caregiver in this case not only is reporting better cognitive improvement, greater confidence in the technology, but he has more time to himself because the patient can make the rehabilitation all alone without itself, and of course she doesn't have to bring the patient to the clinic. So these two conditions are very different, and explain how the technology can have a different way of use in rehabilitation field.